Thank you very much. So in 7 minutes, we are going to cover prevention and treatment, both non-pharmacological and pharmacological. That's quite a challenge. Okay, so as Rune Larsen very nicely explained, this is how it is to stay in hospital. So imagine you're in that bed with a hip fracture, with some pain, you're thirsty, you're not sure where you are because you might have a cognitive impairment already. You're not sure why you're there, and you're totally lost. This is exactly the same room, but something has happened. So what is good delirium prevention and delirium care is how do we get from the situation on the left-hand side to the situation on the right-hand side. If you just remember this and try to implement this for all of your patients, then you're almost done. Okay? So that's my take-home message. So if we make a list, what is this about? It's about to mobilize the patients a little bit more than you think is possible. Always try a little bit more. It's about keeping the surroundings safe. Avoid moving the persons unnecessarily between rooms. It's about helping the patients to understand what is their situation. Where are they? Who are you? Why are you there? What is going to happen the next minutes, the next hours during this day? And as was said, be sure they are wearing their hearing aids or glasses. If I'm in a hospital without my glasses, now I cannot see your faces. So, important. Make sure support is provided by carers who are familiar to the patients. We heard that 20 persons are involved from the patients are getting sick at home and to the emergency department or to the ward. There are new faces all the time. Try to keep that amount of shifts as limited as possible. Consider involving the family, if possible. That can be really helpful. It can also be distressing. So the family needs some education about what is delirium, why is the patient like this, but should be considered. Not only encourage the patients to eat and drink, but make sure they are actually doing this. Give them intravenous fluids early. They are not asking for this themselves. We have to do it for them. Avoid using a catheter or things that hurts or is painful if it's possible. So it's possible sometimes, but on the other hand, if the patient has urinary retention, then they need a catheter. So this is not a quick fix, but you have to think about, is it possible to remove some equipment that it's not really necessary now? Pain. Pain is a trigger for delirium. We are sometimes afraid of giving painkillers because we think, okay, opioids will probably make them more confused. I would still say try to do the best to make sure that the pain is well managed. That's like the base. And if they are getting confused, then you know why. Because pain is a very strong trigger for delirium, and it's something we need to address. I'll come back to some things after. Avoid disturbing the sleep, so not waking up the patients for unnecessary monitoring at 4 o'clock in the morning. For doctors, review their medications, take away all that is not strictly necessary right now. Some might be directly harmful for their brains. And on the other hand, they might need some more medications, like more patients for their diabetes or their heart failure, or So do proper review, and address constipation and urinary retention. It sounds very simple, but it can be really a strong trigger for delirium. And on the top here, all the time, as Alistair said, be delirium aware. So teach your department about delirium. It's not very difficult to put up this list. And it's very important that you have to do all these things together. So evidence has shown that these kind of multi-component interventions is effective when it comes to prevention of delirium. And it's not enough just to focus on one thing here. So we have to do it systematically and as a routine. And that means that it is not possible to just rely on one very enthusiastic doctor or one very skilled nurse. We have to involve the whole multidisciplinary team and to learn the team to do these things together. So it has to be done systematically and as a teamwork. Okay. Some other aspects about the basic treatment of delirium. It's essential to find and treat the underlying causes. If it's a hip fracture, it's obvious and they need a surgery. But also, it's very important that these multimorbid patients, they have a lot of comorbidity, and we need to optimize their physiology, like rehydration, be sure they do not have anemia, that their blood sugar is not too high or too low, and etc. And then the hard thing is, how do we manage their behavioral symptoms and distress? And we have to prevent complications because, as Rose shown, if you have a patient with delirium, the whole stay is more complicated. They get more complications. So, should we use drugs? Probably we all have used drugs. And what are the best drugs? I will keep this very short. What is the evidence? We know that when it comes to antipsychotics, it's shown that there's no difference preventing delirium with antipsychotics. We do not have enough evidence regarding delirium severity, and it's not, sugar pills. It has potential harmful side effects. So that's for antipsychotics. When it comes to benzodiazepines that we are often using, there are very, very few studies, two quite, not very strong studies, saying that it's neither safe nor effective for patients with delirium. Then we have guidelines that are evidence-based, based on all available evidence, and with an expert consensus saying that, okay, we can use drugs, but then only for intractable distress or imminent risk of harm, with low doses and short treatment and a plan for stopping the treatment. And in Australia, they are even more strict. They said we should really avoid use of antipsychotic medicines. So that's the evidence, that's the guidelines. However, there are some limitations. It's really hard to do proper trials. It's really hard to discuss what is a meaningful outcome when it comes to delirium trials. Is it to say delirium yes or no? Usually the trials did not include distress-specific outcome measures. But now, the last couple of years, it's suggested that if we are going to do some trials, we should include patient-centered outcomes like emotional distress and cognition, also long-term cognition and health-related quality of life in our studies. So, more important than discussing what is the best to use as a drug, is it haloperidol or is it lorazepam, or when is it appropriate to use drugs? And you should have those discussions on your ward. It could be if severe distress or safety issues, and then it's suggested to use low doses of antipsychotics for a short time. In the ICU, dexmedetomidine might be an alternative, and benzodiazepines should be reserved for only withdrawal delirium situations or high level, I think, of anxiety. And it's very important that there is not a cure for delirium, so we still need to do all the non-pharmacological interventions at the same time. So just one slide to wrap it all up. You can check up this review article from Anesthesia a couple of years ago. It's a summary of what I actually said now. We should identify risk factors like hip fracture. We should use all the multi-component interventions. For pain, fascial iliac block should be considered, and pain should be treated. We should avoid using the benzodiazepines, and perhaps also dexmedetomidine or other drugs could be useful, but the evidence is quite scarce. So I'll just do like that, and thank you.
Okay. Any questions?